Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to go through a few different papers. Not all of them would be considered original experimentation. As a matter of fact, most of them wouldn't. What they are is some commentaries, one trying to set something up for future use. One of them is I believe it's a systematic review. I believe systematic reviews have very, very specific guidelines for how you do them step by step. So we want to say that out loud first because it's going to relate to the points I'm going to attempt to make. Okay, so I have definitely spoken about evidence-based medicine in the past and said that I do not necessarily believe it is exceptionally useful in the practice of hands-on manual therapeutics, especially with respect to the teaching of them. One of the arguments that I have made is that evidence-based medicine has step-by-step protocols embedded within it in order to do it consistently between people. So you're considering inter-rater reliability or inter-rater similar search steps so that conclusions can be stable. It is from a positivist, aka epistemologically, it fundamentally believes there is a singular reality that can be identified through appropriate experimentation, and the observer is always the issue. There are definitely phenomena where that is probably the best approach to take. Healthcare, you can argue that that is sometimes the best approach to take, and sometimes it is not. Because a positivist who believes there is a singular reality, when they assay a wide population of patients, will note that patients are different. They are variable. So if the singular reality is that people are different, then you already know that because you're a positivist. So I do not fundamentally take issue with the positivist approach where it is appropriate. I would be in favor of it in most cases. I'm going to read the abstract of what would be considered the first paper outlining evidence-based medicine. Gordon Guyat was the primary author. It is called, and you can find this, I'm not going to link it, I am purposely not linking it. I want you to do some work if you care to look at what I'm talking about. The title is Evidence-Based Medicine, A New Approach to Teaching the Practice of Medicine. In its title, at inception, now there was work done in this prior, so I believe the first individual who did work prior would be David Sackett, but the first paper that is considered, as far as I'm aware, and give me a paper that would be considered more the first paper explicitly talking about evidence-based medicine, and I'm happy to read it, but right now, the one that I can find that is pointed to as the first paper is this one. The title again, Evidence-Based Medicine, A New Approach to Teaching the Practice of Medicine. At inception, the title of this tells you that this is a teaching methodology. If it is a teaching methodology, then it is subject to examination in that light. It is not necessarily a guide for how to practice at all times. At inception, it may very well have evolved into that, and arguments made in that direction. Completely acceptable. I'm not examining that, but what I'm telling you is that the base of evidence-based medicine, it's a teaching method, okay? Subsequent to this, other things pop up. So there are steps in order for how you do the things it's trying to teach you. It is a rigorous, step-by-step approach that is requested to teach medical practitioners and hope that they will continue to do the exact same steps in the exact same order in future, okay? The abstract to read, a new paradigm for medical practice is emerging. Evidence-based medicine de-emphasizes intuition, unsystematic clinical experience, and pathophysiologic rationale as sufficient grounds for clinical decision-making, and stresses the examination of evidence from clinical research. To stop, nobody's going to fight you on that. You should have as much information and as much base knowledge as you can prior to decision making. That's a given. This is adding nothing new. You can argue that the steps it adds, subsequent to making this argument, would be considered new in format, but it has added nothing new. And this is in 1992. Keep this in mind. To read again, evidence-based medicine requires new skills of the physician, including efficient literature searching and the application of formal rules of evidence evaluating the clinical literature. Okay? It is entirely possible that prior to this, you could make the case that there was no standardized approach to teaching people how to evaluate literature. What this is setting up, if you are aware of how people attempt to teach the building of research questions, is the PGH model, the problem, the gap, and the hook. And also the PGH model is supported or taught as something that is going to help you with respect to getting funding, right? You have to show why investigating the thing you're interested in investigating is going to be useful so that a funder would be willing to accept your funding application or your research grant application, okay? So the PGH model does underpin this. He's showing what he believes, or this author group rather, Guyot as the primary. But the other group is showing why you need this further step-by-step approach. You want to standardize the approach so kind of everybody's doing it the same. What I will always argue is that standardized approaches are great starting places. However, they will increase creativity within the box or within the bounded solution space, but they will not allow for, or they will make it much harder to search for solutions that are necessary outside of the bounded solution space previously provided. Okay, so it's good, but there are limits to it. To read again, an important goal of our medical residency program is to educate physicians in the practice of evidence-based medicine. Strategies include a weekly formal academic half-day for residents devoted to learning the necessary skills, recruitment into teaching roles. Okay, so step by step from base. What we're going to do is we're going to have dedicated academic half-days for residents. We're going to teach them the necessary skills. We're going to recruit into teaching roles. So we're going to try to reproduce this specific methodology into instructors who will then go to other places and reproduce this specific teaching methodology over and over and over again. That is the aim at inception. Okay. Then to read again, and providing faculty with feedback on their performance as role models to teachers of evidence-based medicine. The influence of evidence-based medicine on clinical practice and medical education is increasing. The initial paper was a step-by-step manifesto of how they were going to inculcate this into residents and then inculcate it into instructors and teachers in residency programs. It's a step-by-step method for evaluating research. It then evolves and adds more. You get the grade protocol. Please excuse me that I don't remember the exact acronym breakdown for grade, but it is essentially the step-by-step method in acronym for how you evaluate medical evidence or how you would generate it. I believe the first G is gather, right? I'm admitting that I'm not sharp on that. So the acknowledgement of that lack of sharpness, take from that what you will. But EBM is a teaching model with rigorous steps. Okay, so I'm going to shift to something else. Where do I want to go to? There we go. Okay, so the first one, where in the heck did that go? Please excuse as I search for the thing I thought I had. There it is. Okay. What? All right, so 2001, yeah, 2001. I'm going to go to a 2001 paper. So the essentially initial paper in EBM is 1992, 2001. There's discussion. If you want to talk about, I'll tell you how I found this. My background as having a Master's of Science in Health Science Education occurred at McMaster University in the Department of Health Sciences. The subgroup is Health Science Education. So I have an HSED Master's in Science. The individual who set that program up is named Dr. Jeffrey Norman. Dr. Jeffrey Norman is one of the notable people in health professions education or health science education. You're also going to see Kevin Eva. You're going to see, I believe, Pim Tunison. There are other names that are escaping my head just because I didn't purposely get sharp on them. Pim Tunison, who else would you see as earlier names? Kevin Eva, I believe, is in Ottawa. Pim Tunison, unless I'm going nuts, is in the Netherlands. So the two big universities with respect to health science education, health professions education, as far as research is concerned, is McMaster University in Hamilton and Maastricht University in the Netherlands. There are definitely other names. There's a name in America that I cannot recall off the top of my head, so please excuse me for that. But I'm going to read the paper from Dr. Norman. This is essentially, what would you call this? It would be called a critique. It would probably be a critique. So as formal methodology is concerned, this is not formally methodologically built. However, it is commentary and critique. So the title of this is from 2001, Examining the Assumptions of Evidence-Based Medicine. Dr. Norman has a background first in physics. He has a PhD in physics. Then he was doing a lot of research assisting at McMaster with respect to the medical school. And he ended up getting a master's in clinical psychology from the University of Michigan, where clinical psychology was growing quite a bit at the time that he got his master's there. Because he was already working in health science or medical education, and then he went and did more. He was very, very heavily involved in a lot of the early research in problem-based learning at McMaster. He does not necessarily support problem-based learning at this point, aside from student engagement as far as I can recall. But just to kind of give you some background so that you know where Dr. Norman would be coming from. And this is 2001. This is not recent, and it is not terribly far from that initial paper. So to read the abstract of what Dr. Norman wrote here, again, this isn't the full thing, but it's to give you a flavor. So I'll just let this speak for itself. I don't need to make commentary initially. Evidence-based medicine, EBM, has had enormous impact on clinical medicine, attracting both converts and detractors. The basic premise that clinical decisions should be made on evidence which is as sound as possible appears unassailable. I just, as commentary, I don't know how you're going to argue with that. So Norman is laying out there are people in support of and people against, but the terms evidence-based medicine and the initial claims, you're not going to find people fight with that. Yeah, you want the best evidence. Why then, to read again, why then has the idea stimulated such controversy? In this article, I examine 6 assumptions of EBM and point out how these assumptions are frequently open to challenge. Prior to reading this, if memory serves properly, in the abstract there's only 5, but it says 6 here. So either there's a spelling error or like a writing error in the abstract, or they only included 5 in the abstract. Yeah. In this article, to read this again, in this article, I examine 6 assumptions of EBM and point out how these assumptions are frequently open to challenge. Finally, I make specific recommendations for future activities to ensure that the strategy achieves an appropriate role in healthcare decision-making. These include 1. Conducting research to establish the effectiveness of EBM. As far as I'm aware, I believe the paper that I will go to shortly is 2024. It hasn't shown anything with respect to patient outcome yet. It doesn't mean it won't. It just means as yet, as a teaching method and as a practice method, the evaluation as far as I can find, and it doesn't mean I found everything. It just means that when examined, the state of literature as it exists doesn't show any change in patient outcome. Again, it doesn't mean that there is no change in patient outcome from this approach. It just means it hasn't been shown yet. And realistically, it actually hasn't been measured. 1. Okay, so we got 1, we get 2. Incorporating, as they apparently are, more holistic perspectives on the nature of evidence. Okay, so one of the criticisms generally is what qualifies as evidence, and if you believe that the top of the pyramid is meta-analysis, then you have an immediate issue. Meta-analysis has issues I'll discuss shortly. It doesn't mean meta-analyses are not good. It just means they have inherent issues because of how you're required to do them in a rigorous fashion. You make an axiological or value-based choice that you're okay with those issues, but if you don't acknowledge those issues and you defend without acknowledging those issues, you're putting yourself in a position that is difficult to deal with, right? Or difficult for you to continue moving with. 3, moving as they are toward the use of expert reviews and away from a focus on the skilled individual practitioner. 4, examining the literature on continuing education to devise more appropriate dissemination strategies, including specifically educational influentials. One of the things, very broadly, I'm not pointing to specific papers here, but I'm acknowledging that some of this is from stuff I've already experienced and seen. Continuing education schemes or continuing education approaches don't often show much change in behavior. So on task, clinical behavior doesn't seem to change with continuing education. It's one of the reasons you see multiple professional colleges, regulatory colleges, professional associations moving towards varying methods of continuing education models, which also really have no support for how you do them. You just kind of do them because it's tradition. It doesn't mean it doesn't help anybody, because there's definitely people who will benefit extremely highly from continuing education, but because it's a forced activity, most people treat it as if it's a forced activity. It's a checkbox, it's a hoop to jump through just to make sure I can keep doing the thing I want to be doing. Number 5, making specific attempts at conciliation and seeking common ground with other schools of thought. Because I don't have the full article, I am going to point in a direction that I think Dr. Norman may have been pointing, that there is competition between schools of thought at the time, and this is 2001, with respect to how you would approach the examination of literature, the application to clinical decision-making, as well as teaching models. This is before a lot of stuff has been ironed out. Health science education, health professions education isn't exceptionally young, but it's, say, fuller examination of how you go about teaching health professionals to become full-on health professionals or health profession students to get there. It's young. It's not necessarily young in years, it's young in experience, but it has exploded quite a bit, probably, let's say, since 2010. There's a lot that happened prior to that, but 2010 on, there's a lot more, say, full-throated investigation. One of the things, this is where I get to say what I've recognized as why EBM gives me so much challenge. Because I did not know that it was initially built as a teaching model, but because I am in tune with teaching models because of additional training that I chose to do in order to get my Master's of Science in Health Science Education, there are things that it doesn't account for that are automatically going to populate my head when I'm looking at things, because I am considering cognition, I'm considering models of cognition, primarily networks of related meaning or semantic networks. If you want to look at a bunch of really good stuff on that, you can look at Dr. Nicole Woods. I do not know if she's slowed down in publishing a little bit, only because when I looked, I didn't see as much recent stuff. I've definitely seen stuff from 2024 and 2025. I don't know because I haven't been paying a bunch of attention, but Dr. Nicole Woods has done a lot about that. Primarily what you're going to see is the combining content and cognition. So the skill with the underlying concepts of why you do the skill. So it would be basic mechanism. Now, I would say that that applies much stronger in medicine, and especially in surgery, but medicine generally, because if you understand the basic science, then your ability to adjust as is needed to the patient because the patient's different. So adjust even physical positioning. Dr. Jeffrey Chung, I believe he's at a university in Illinois. He did some stuff on this. What he did was he examined combined content and cognition for lumbar puncture on a model. So the model being a training model, it's a simulator. And then he had it in a normal position and he had it in an abnormal position. And those who were trained with content and cognition combined seemed to do better at the transfer task. So the ability to adjust seems to be better predicted by combining basic science mechanisms with what you're doing. So you know why you're doing what you're doing. And that seems to predict better ability to adjust as is needed to the circumstances. The fundamental flaw in using previous evidence in clinical circumstances is that it will not likely have done that job, the job of adjusting for novel circumstance, prior to getting to you. You can extrapolate and abstract, but the existing evidence may not be germane to the uniqueness of the situation that I'm working in. Therefore, if I want to train people I want to train them more heavily on the ability to transfer, aka the ability to deal with novelty. The more expert you become, the more talented you become at dealing with novelty, but we can prime that earlier. At no point will I ever suggest that in the step-by-step approach, EBM does not include clinical expertise, because it does. But what it says is it wants evidence first in the hierarchy. The way that you determine that is it says, examine evidence, apply conscientiously and judiciously in concert with clinical expertise. So it does point in the direction of the clinical expertise being exceptionally central and important. However, because it's a teaching model, it is missing some basics. It was developed at a time when we weren't as aware of combining for content and cognition. We just didn't know. So if it is not doing that, and if you are staying rigid in applying the teaching methodology of EBM, you are behind the power curve. You are very, very far behind. It doesn't mean that is malicious. It means you are just missing information. And that's the fundamental sort of pain point for me, because I happen to have learned more, not because I am superior or that I am more of an expert. I just know another piece of information that makes it much harder for me to deal with the claims of EBM. Right now, to move on from the 2001 paper, I am going to go to another paper from Dr. Norman. And what it is, it's a commentary, right? And it's talking about, so to point to what I just talked about, how basic is basic science, okay? So I'm going to read this. This is the full text. It's not a gigantic paper by any means. I can kind of get to the point pretty quickly with it. And this is from, when is this? 2007, okay? A couple of years ago, Michael Whitcomb, editor of Academic Medicine, wrote an editorial, Whitcomb 2005, where he pleaded for a downplaying of basic science in favor of other aspects of medical education. A caricature of the argument goes something like this. So before I read the caricature, Dr. Norman said this is a caricature of the argument. He is admitting to what he's doing in order to be able to write more. He's setting his foundation, but he called his foundation a caricature. Okay? Number one, practicing clinicians don't practice evidence-based medicine. Two, clinicians today are all getting sued because they have no interpersonal skills. Therefore, three, we should teach less basic science. Okay? I need you to understand Dr. Norman did quite a bit of fundamental work with respect to basic science and its application to teaching in medical education. I'm not 100% sure if Dr. Norman was Dr. Nicole Wood's PhD supervisor, but he definitely has done a good amount of work with Dr. Woods. Come back to read again. Some other possible conclusions come easily to mind. Perhaps if we're only concerned about students learning evidence-based medicine, then we should teach it more or better. On the other hand, I am one of many who have joined the anti-EBM movement, Norman 1999, so I didn't necessarily look at that paper, but that paper exists. It's another paper that Dr. Norman wrote about why he is anti-EBM. So before 2007 and before 2001, he has noted in writing that he is against it. And now, when I say he's against it, he would have provided rationale for why he views it as negative, or maybe not negative, maybe not as beneficial. To read again, in my view, the fundamental irony remains that even though it made BMJ's top 15 medical innovations of all time list in 2006, it remains saddled by the paradox that it uniquely, among the innovations, contains the word evidence in its title, yet cannot marshal any evidence whatsoever that EBM makes any difference to patient outcomes. Of course, EBMers are masters of obfuscating about why such a study could not be done. Too many confounders, educational research is too soft to meet the rigorous standards of EBM, etc. Methinks the maiden doth protest too much. So, with respect to medical education, Norman is talking about how EBM doesn't want to do the studies there, or those who would be in favor don't want to do the studies on the education side, aka we can't figure out whether applying this is going to do anything for outcomes. I'm going to really quickly click on that 1999 paper and see if it pops up. Where the heck are you, 1999 paper? Oh, yeah. No, I think I already pointed that. What the heck is going on with me? Examining the assumptions of evidence-based medicine. That's the one. Sorry, I did already do that. I just screwed up in not recognizing that that's what he was referencing when he wrote his stuff. The rest of it goes on to talk about Dr. Nicole Wood's work with respect to teaching basic science along with clinical skills so that you can prime for transfer. Now, again, note Dr. Norman set up the program that I went through, so it is exceptionally likely that I'm going to be more in line with this approach because the people that would be populating that program as instructors are probably going to be aware of this work. It's going to inform them. I will tell you from personal experience that not everybody in that HSED program agrees. There are a variety of perspectives. There are a variety of epistemological approaches or approaches to how knowledge is built. The better way to put it, let me do it this way because it sounds better. Epistemology is answering the questions, what can be known, how can it be known, and who can it be known by? And the people in the HSED program are not the same epistemologically, and that's probably one of the reasons that they're there, and the associated merit. McMaster Education Research, and I always screw up the I and the T, but I hang out at their events regularly. I go to Nerd Day, the Norman Education Research Day, and I have had a few conversations with Dr. Norman, so it's not simply that I read his stuff. I have actually met him and interacted with him in what I would call an academic and intellectual way. So that means that I am likely going to at least be informed by this stuff. Hence why EBM, and I didn't know this because I never looked for this before. I didn't find this stuff prior, but the critiques of EBM that I've had in the past are underpinned by what I'm pointing to. So I'm sewing it together with exemplars so that it becomes more obvious as to why I take the approach that I take, and it's primarily for teaching. Okay. The final thing that I'm going to go to, this is from 2019, so I screwed up. It's not 2024. So it's entirely possible that in the intervening time between 2019 and 2024, that there is stuff that I haven't seen. Okay. The query that I gave Google Scholar was evidence-based medicine and patient outcomes. Now, prior to talking about this, what I want to talk about is meta-analyses. Meta-analyses generally are highly rigorous. They begin with a research question. That research question has to have specificity. It also intones axiological value-based judgments. So the format of the question that you ask means that you are choosing to look at specific things. One of the steps, regardless of meta-analytic approach, is that you have to have strong inclusion and exclusion criteria, and you should express them. If you have strong inclusion criteria, you are making a value-based choice to include certain things based on certain characteristics because you're trying to answer an exceptionally specific question. You are using aggregated data that already exists, but it's still a specific question. Okay, so on that level, because you are including things related to the specific question, you must then admit that you are not representing the full breadth of research available. You are evaluating the exceptionally narrow band of what you chose to include. To further that argument, you have strong exclusion criteria. So when a paper looks like it might hit your question, you have to evaluate it and include it or exclude it based on the preset criteria. In noting that you exclude things on purpose, although they may fall into the scope of the general range of evidence about the question, you are noting that you are actively excluding it. Therefore, meta-analyses cannot be appropriate representations of breadth of available evidence. It can be noted specifically that it is evaluating the chosen included information. You defend that choice based on your criteria, and for the most part, those criteria are defensible and fine. To say it in a more colloquial way, if you've got your inclusion exclusion criteria you're probably in a good place. Now, that said, meta-analyses do not synthesize general information about a particular topic. They have specific research questions. They are narrow in a wide sea or a wide space. So to say that they are synthesizing the general evidence, that is not true. They are synthesizing the evidence that was chosen to be included based on the values of the researcher and the specific question being asked. So they have flaws. They are missing stuff. They are making value-based judgment on what evidence is and what evidence is not with respect to the specific question. They have value because if the specific question being posed applies close enough to the situation that you're dealing with, you include it in your decision making. But it doesn't mean that it's perfect or that it is the top of a decision-making hierarchy for a unique situation. So, that said, now you know some of the challenges with meta-analyses, but meta-analyses are beneficial. One of the things that you run into with meta-analyses that is exceptionally challenging is that some fields, their epistemologies or their method of knowledge building is varied, so it makes it harder to apply meta-analysis to that because meta-analysis does better when the methods of data collection are similar. So some fields are better and not better. Some fields are easier to do meta-analysis to. Some fields are harder to do meta-analysis to. Medical education is much harder to do meta-analysis to because it is a more varied multifactorial thing because you're dealing with interpersonal interactions, you're dealing with hard, say, medical data, hard physiology, hard anatomy, but then you're dealing with interpersonal skills, you're dealing with behavioral psych, cognitive psych. It is much harder to do a meta-analysis there. So it just, as a method of attempting to collect data and make a point, meta-analysis doesn't do exceptionally well because the answer to almost all meta-analyses in medical education or health professions education is, there isn't all that much data out there on this particular topic, and some of it's fine and some of it's questionable. Therefore, this is kind of what we can interpret. So let me read this one. This one is called, Does Evidence-Based Medicine Training Improve Doctors' Knowledge, Practice, and Patient Outcomes? A systematic review of the evidence. So there's systematic reviews and scoping reviews. This is systematic. I don't remember all the steps, but this is a rigorous approach, and I have the abstract, not the full text. To read, courses in evidence-based medicine for doctors have consistently demonstrated short-term improvements in knowledge. However, there is no strong evidence linking EBM training to changes in clinical practice or patient outcomes. This systematic review investigates whether EBM training leads to sustained improvements in doctors' knowledge and practice behaviors that may also facilitate changes in patient outcomes and experience. A literature search, so you need to understand that they were querying for changes in outcome and positive changes in patient experience. So they had multiple things that they were looking for. So their inclusion criteria got a bit more broad. Blah, 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 blah. Literature search was undertaken in Ovid Medicine, Ovid MBase, the Cochrane Library, ERIC, and Scopus. Studies published from 1997 to 2016 that assessed outcomes of EBM educational interventions amongst doctors and used measures of knowledge, skills, attitude, practice or patient outcomes were included. 15 studies were included in the analysis, 4 randomized control trials, 3 non-RCTs, and 8 before-after longitudinal cohort studies. Heterogeneity among studies prevented meaningful comparisons. So remember I said that the data collection makes it hard to do meta-analysis on some things? Here you go, right? It's one example. It's not all examples, but I've seen this many times. Go back. Varying degrees of bias due to the use of subjective measures were identified, limiting study validity. Results showed that EBM interventions can improve short-term knowledge and skills, but there is little reliable evidence of changes in long-term knowledge, attitudes, and clinical practice. Remember when I said CEU stuff doesn't show much change in how people practice or how professionals operate? This isn't necessarily looking at that, but it's a point in that direction. No study measured improvement in patient outcomes or experiences. EBM training for medical practitioners needs to incorporate measures of behavioral changes while incorporating patient outcomes and experience measures. So they are up to 2019. Really, it's up to 2016 because that's when they closed their search. So maybe between 2016 and 2026, there's more stuff looking at it. I am not aware of it. So again, you have to keep in mind that I'm noting the limits of my knowledge or the limits of what I've seen. But EBM as a teaching model doesn't seem to do much. One of the problems you run into with health science education is that the individuals who are engaged in it have gone through multiple filters. They are also likely highly conscientious, likely highly skilled, likely highly knowledgeable before they get into medical education, and definitely before they get into practice. If you get into practice as a physician, you're probably smart, you're probably hardworking, you're probably going to do good no matter what situation you're in, you're going to find a way. So you're not necessarily going to see large outcome impacts of any intervention, especially not one that's step by step, because the practice of healthcare is messy. Now, you have to understand that most of what I'm talking about comes from medical setting, physician setting. In hands-on therapeutic settings, the stakes are lower. They're less complicated. The amount of evidence and form of evidence we can collect is much lower and much less explicit and granular. We're observing people from the outside. We're getting proxy information at best. We are fantastic at identifying situations where we should not do. We're pretty damn good at gross pathology, which is a way to say, I probably shouldn't go here, I probably shouldn't do this. Pathophysiology? No, we are not good. We cannot gather that evidence exceptionally well unless we have the legal right to do things like imaging and blood testing. And for the most part, we're not going to. So the application of EBM isn't particularly ideal. Also, when you look at the state of literature writ large in hands-on therapeutics, the ability to extrapolate through meta-analysis is difficult. However, if you consider that there is normal variability between people, between their preferences, between what they respond well to and what they respond poorly to, then a FAR transfer paradigm, a problem-solving paradigm, probably applies better to hands-on therapeutics. So, you've heard again my critique of EBM and its position in healthcare practices that are not medicine. You've heard more about some of the challenges with meta-analysis. You've heard the critique of EBM from Dr. Jeffrey Norman. There are other people who have critiqued it. It has been critiqued since it showed up. But remember, at its inception, it is a teaching model. It is attempting to be a teaching model for a rigorous step-by-step approach to practice that does not include forms of evidence that would be useful in a lot of healthcare situations, such as qualitative information. It doesn't mean that it wouldn't include it. It means it's hard for it to include it. It's a very incomplete approach to clinical decision-making. Also, there's a huge amount of stuff on clinical decision-making that would never line up with EBM, especially at its inception to now. Clinical decision-making, there's a lot of challenges with how people talk about it. Again, I just happen to be academically related to people who have done a good amount of work at the cutting edge of clinical decision-making. One of those people happens to be my thesis supervisor, Dr. Sandra Montero. So if you are going to discuss those things, I'm happy to do so. I accidentally learned a good amount about those things. And those are why, so essentially the teaching aspect and the decision-making aspect are why I have hard challenges with something like EBM attempting to be applied in a place it wasn't built for. Hands-on manual therapeutics is not the place that EBM was built for. It was built for medicine. It was built as a teaching model with the hope that people would just do it over and over again. They even had a manifesto and a plan in that paper that I showed you to take over the teaching world. I'll tell you it didn't work because it doesn't line up with the best practices and the evidence appropriately in a very unfortunate way. It sounds really good. It would be lovely if it worked, but it's just not the top of the top, okay? You have good endurance for listening this far. Thank you very much for listening this far. I hope you've learned something, and we'll talk again soon.